have a feeling it's something like we turn on this turn on system. PC to begin select. .cam lap. I don't know what this is. PC, I guess. Hi. So is that correct? Just warm that up. Okay. And so this is not. This isn't good now. Maybe I don't know whether it needs batteries or there's something. Okay. There's something else to put on there.
I think it's a little lower battery, so we'll replace it to
The other question I'll have you is putting a CD in to play a CD. There's a CD drive here, but do I just go to computer and then we just hit that?
Yeah, we can.
Okay, so this will, if on, will you be here Monday doing this?
No, someone else will be working Monday. We'll make sure that
if they can get here about like 5 minutes early, because the.
15 minutes early.
Oh, okay.
We'll
Because but that'll 1 year they didn't come. I mean, like and it screwed up the whole CD. We have to start with the CD. So.
Okay.
Okay, so we're in business. Can we do a pointer here? Or, the mouse is always very hard. I mean, you can use it, but.
I heard that lecturers use the mouse just because it shows up on the recording.
Yeah, it's just much harder to use. Let's see. Maybe we could. Well, you know something, if this is what we've got, this is what we use. Okay, we'll use this. Good. Okay. I think if Dr. Garrett is ready, we're ready down here. Okay? So we'll get started because we have a lot to do today. I'm Dr. Jerry Appel with J. Radhakrishnan. I co-run clinical nephrology here, and I have for many, many years. And we're going to be talking about a very important topic. First, here are my conflict of interests. The only line is really the bottom line is the important one here. Columbia University makes me put this in, the bottom line. Okay, so we're going to talk about acute kidney injury today, and we'll go through the different patterns, we'll go through the diagnosis of acute kidney injury, we'll go through how you would treat this based on knowing the different patterns of pathophysiology, and then we'll get a little bit into treatment as well. So we're going to start with a case, though. This is a 73-year-old white female with a history of diabetes and hypertension, but she has normal renal function. Her creatinine is 0.7 milligrams per deciliter. That's normal for her. She has normal kidney function. She develops an infection of her right foot. For 1 week, she's had fever, chills, swelling of her right foot, and then her right leg. She takes Motrin and nonsteroidals for pain. Her urine output drops down. She comes to the emergency department, and there she's found to have a blood pressure of 82/60. Now, I can tell you there are probably some young ladies out here who have a blood pressure of 82/60, and it's normal. But if you're 73 years old, a blood pressure of 82/60 is never normal. That's as low as can be. Her temperature is 102. Her heart rate is 88. She's confused, disoriented, but her examination of her heart, her chest, abdomen is all normal. She has, on the extremities, severe cellulitis, an inflammation and infection of the soft tissue of her right foot and her right leg. When they do her laboratory evaluation, and these are evaluations that they do on every single person who is admitted to the hospital, and that's true for almost every hospital in the United States. It's a routine screen. You look at the blood urea nitrogen, her level is 106. Normal is 10 to 20. Her plasma creatinine, which was entirely normal in the past, is now 6.6. That's almost at dialysis, or is at dialysis levels already, indicating almost no function. She's treated with fluids, antibiotics, and dialysis. Now, we will return to Grandma Ida in a little bit longer, but let me tell you, this is extremely common. So the first thing we have to do is go through the nomenclature here. Then we have to tell you why this is so significant. This acute kidney injury is so important. This exact scenario will probably change for next year's class, because next year's class, I'm going to use the 45-year-old who came in with cellulitis, my patient who's been in the hospital for the last 5 days, and right under our noses developed, again, AKI with a rising creatinine. So this does happen, and it was the same etiology, as you'll see. So here are the questions we're going to answer today about acute kidney injury. One, how do we know the patient has AKI? What's the definition? How do we know they have it? Two, what is the significance for her, for the population in general, of AKI? Three, what are the possible etiologies? What are the causes of AKI, and what are the pathophysiologic mechanisms of each cause? Most important, how do we use this, knowing the different causes, to reach a diagnosis, and using the pathophysiology, how do we treat this or prevent it? So these are the things that we'll try to answer in the next 45, 50 minutes. There has been a change in nomenclature. The disease is the same. It's never changed. It was the same when I was a medical student, when my son was a medical student, right here, and now when you're medical students, except the name has changed. It used to be called acute renal failure. A lot of people didn't like that because failure didn't sound like you were doing such a good job. So then they changed it to acute renal insufficiency. But that wasn't so good, because if you had severe AKI, it didn't fit very well. It wasn't just insufficiency, it was the kidney wasn't working. So now people use the term acute kidney injury. You will go through the next 4 years using acute kidney injury, your house staff training. In 10 years, I have no doubt there'll be a different name, but they'll still be talking about the same entity. So you may see on some of the slides where I still call it acute renal failure, but it's the same entity. So what's the significance? Severe AKI occurs in 5 to 10% of hospitalized patients. It occurs in up to 25% of the patients in the ICU. The mortality rate, if you have severe AKI, is very high, and we'll look at that in a few minutes. Even if you don't die from it, it contributes tremendously to the morbidity of a critically ill patient. You take somebody who's sick, who comes in with sepsis or postoperative problems, you add on renal failure, and they're in big trouble. The correct diagnosis and treatment, again, depends upon the pathophysiology. It's one of the areas where you really can say, look, this is what I'm doing because this is what I think the patient has, and it's based on what you know about their pathophysiology. This is a study I like to show because we'll come back to it several times. It's a study of over 4,600 patients, consecutive patients, admitted to a medicine and surgery service of a large Chicago tertiary care hospital, major hospital in Chicago. Acute kidney injury occurred in 7% of the patients, more than 7%. The mortality was 20% in those patients. For severe AKI, if the creatinine got above 3 milligrams per deciliter, and we already said Grandma Ida on the first slide is up at 6, so she's in trouble, the mortality was 38%. Now that is really high for any admission diagnosis. What were the causes of the AKI? The most common cause in that series, and it'll be different over time in different series, was a low blood pressure and low renal perfusion. The kidney just wasn't getting a good blood supply. Very much like the patient here, the blood pressure is very low. When the blood pressure gets below a certain point, you just don't get enough blood flow to the kidney for it to work and filter. So that was the most common. Medications were extremely common. And our patient here got antibiotics. My much younger guy, the 45-year-old who has AKI in the hospital, he was getting nephrotoxic antibiotics, which are extremely common. Radiographic contrast agents are a significant cause, and we use these all the time. We've changed which contrast agent we use, but we're still doing tons of CAT scans with contrast. Post-operative, you just can't get away from this, that a certain percentage of people who go through an operation will have either major bleeding and get hypotensive, or they'll get some other problem that leads to sepsis and hypotension, and sepsis itself, 8%. These are still the major categories. The percentages may change, it may be different for different hospitals, but these are the things that produce acute renal failure, AKI. So we said that the mortality associated with this condition depends upon the severity. You can use the serum creatinine, the rise in serum creatinine, and we'll talk about that in a few minutes, why we can, but you can use the rise in serum creatinine to tell you how severe the AKI is. In that series of 4,600 patients, if your creatinine rose up less than 1 milligram per deciliter, the mortality was 10%. If it rose up 1 to 2, it was 22%. 2 to 3, 31%. If it was over 3, severe AKI, 38% of the people died. Now, they didn't die from the renal failure, they died from the renal failure and the other things associated with it. But the renal failure certainly didn't help the mortality. I mean, that is a major problem. Let's look at some other entities. So what about after a heart attack? If you have an acute myocardial infarct, and there are tons of people that have infarcts every day in the United States, you're at risk for AKI. So this is a study that looked at 56 hospitals in the United States. It evaluates 31,000 patients here. AKI developed in 23% of these patients who came into the hospital with an acute myocardial infarction. You could probably pick out the factors, when you start thinking about it. Increasing age, somebody who comes in shock with low blood pressure. If they're starting off with chronic kidney disease to start in a high creatinine, it's easier to bump off the remaining nephrons. Coronary angiography, there's the contrast again. Diabetics are always predisposed, etc. But these are the predisposing causes. The in-hospital mortality was 19% in 2000, 14% in 2008. The problem is it goes up and down. It doesn't change that much. It's not like we're doing a better and better job because there are sicker and sicker patients who are getting these procedures. So even though you do a better job on people, the mortality just sits there. This is the incidence of severe AKI. I mean, how severe is it? Dialysis requiring. You can't get worse than that. And our patient here, remember, had a creatinine of 6.6, so she's at the level where you probably would strongly consider dialysis. If you look at either the population increase, incidence per million, or the absolute cases, it just goes up, up, up. Here it is, dialysis requiring. In 2009, it was 140,000 patients in the United States. It is not a small disease by numbers, and it's a huge disease by morbidity and mortality. Now, in the back of the room, can you read line number 4? No, it's an eye test here. But I'm going to tell you what's on this slide. I mean, I can't even read it from here. That this is hospital mortality, predicted and actual hospital mortality. These are countries from A to U, the United States is down here, looking at the actual hospital mortality of critically ill patients in ICUs who develop severe AKI. And it's all 40, 50, 60%. If you look at the total here, 60%. Again, mortality. If you have, so you can say, oh, in another series it's 39%. In some countries it doesn't, it's how they evaluate it. But the major thing is this is a highly morbid and highly significant condition. And it's a condition that you're going to see again and again. When I attend for my month stretch on renal consults in the hospital here, This is the number one diagnosis. The number one diagnosis that we see is AKI. So, and no day passes when we don't get a new patient with AKI. Now, how do we know the patient has AKI? Well, I know you've already learned about glomerular filtration rate, that we use the markers in the blood of glomerular filtration rate. You could use the blood urea nitrogen, the BUN, and so here's a tip. Don't ever say bun again unless you want to roll. I mean, if you're talking about kidney disease, it's BUN. I mean, like, because, you know, immediately somebody who hears that will say this person knows nothing about medicine at all. Anyway, I mean, I even tell the patients that when they're talking to their doctor, say BUN. But the BUN, the blood urea nitrogen, goes up. But it's affected by a lot of things. It's affected by diet, and it's affected, as you'll see, by different hemodynamics. The creatinine is what we've used the most as a marker for renal function. As GFR, glomerular filtration rate, goes down, the BUN and the creatinine go up. Now, it's important to realize you could lose a lot of function and still be in that normal range. We know that first patient had a normal creatinine of 0.7. That was her normal creatinine, because we know it's her baseline for years. That if she got a creatinine of 1.2, which might be normal for the laboratory, that's still a significant reduction for her. She still might be over here, and the lab might not flag it up. Nevertheless, we know that as the creatinine goes up, when somebody has a creatinine of 6, if they had a normal creatinine before that, that is AKI. It's the only, you know, it's a very solid marker. So we rely either on some measure of the GFR, but the creatinine, the serum creatinine is the best. One way of looking at it is every time you double your serum creatinine, you've halved your glomerular filtration rate. There are a number of different definitions of AKI. This is the Acute Kidney Injury Network's definition. So it'll be slightly different. There are different groups that do it. This is getting more and more accepted, but you'll see that the general thing is there all along. The higher the creatinine, the worse the AKI. So they're stage 1, and I wouldn't spend a lot of time learning the stages. As I said, I don't know in 5 years what system they'll be using, but stage 1 is an increase in the serum creatinine of greater than 0.3 milligrams per deciliter. The autoanalyzers are much more sensitive than that. That's not going to be a lab mistake just because the autoanalyzer can't tell. So if that patient went from 0.7 to 1.1, that's it. She has AKI. Or another way is saying an increase of 1.5 times or twofold. The urine output generally, not always, but generally goes down at the same time. AKI stage 2 is a doubling or tripling of the serum creatinine. You go from 0.7 to 1.4 or 2.1, you're already in a much worse stage. And again, the urine output is low for a longer period of time. Stage 3 is over trebling this, or a serum creatinine over 4. So we know already that that patient is down in the severe stage of AKI, and if we asked her, her urine output would probably be down low for a long period of time. The urine output doesn't always have to go down. The real thing is the creatinine. It often goes down, as we'll see, and we'll talk about why it doesn't in certain situations. So now, having talked about the significance of this, having given you the criteria for this, what is really a definition of this? Well, the definition is AKI is a rapid deterioration of renal function. That is, the glomerular filtration rate is going down. It's associated with the accumulation of nitrogenous waste. The BUN, blood urea nitrogen, goes up. Other waste products go up. Remember, creatinine is not a toxin. It's just a marker we use for the glomerular filtration rate. All forms of AKI typically have an elevated level of creatinine and BUN. So it's pretty hard to pin AKI as a diagnosis on somebody if their serum creatinine was 0.8 a year ago and it's 0.8 now. If the creatinine is up, it's pretty hard to say that it's not some form of AKI, and especially if it's up significantly. Now, there are 3 patterns of AKI And this is probably your first step when you see a patient. You have to ask yourself, well, which of the patterns is it, and what do I need to do to diagnose this? What do I need to do to understand the pathophysiology so I can treat it? So there's postrenal azotemia. This is obstruction to the outflow of urine. There is prerenal azotemia. Here, there's a problem where the blood flow isn't getting to the kidney. The kidney is intrinsically normal. The problem is in front of the kidney. It's the blood flow. And then there is intrinsic renal failure. It can be acute tubular necrosis, which we'll spend most of the time talking about today. It can be acute interstitial nephritis. I'll be talking to you next Thursday with Glenn Markowitz about that. It can be acute glomerulonephritis. I'll be talking to you about that on Wednesday with Dr. Degati, and it can be vascular disease, and I talked to you about that with Barry Stokes. So I've got 3 different pathologists talking with me about these things, but today I'm by myself. So we're going to go through all 3 of them. Postrenal azotemia. This is AKI caused by obstruction to the outflow of urine. The thing to remember, the blockage can occur at any level, from the urethra all the way up to the pelvis of the kidney. As long as there is blockage, you can turn off the function of that kidney. So what are the most common causes of obstructive uropathy, postrenal azotemia? Prostate problems. It can be due to benign prostatic hypertrophy in older people, or prostatic cancer, both very common. In females, gynecologic malignancies. Again, even though some of them are getting less common, this is a common cause of obstruction. Kidney stones are a very common cause of obstructive uropathy, blocking off kidney function by obstruction. If you had to look for one clinical finding that helped you, it would be anuria. Anuria, no urine output, is very suggestive of total obstruction. Now, when I said anuria, no urine output, some people take me literally and say, you have to have 0. What if it's 4 cc's a day? Well, anuria is usually defined as less than 100 cc's a day of urine, because again, small amounts are secreted into the bladder. This is a good definition. If you have less than 100 cc's of urine output per day, you are anuric. You have to think of obstruction highly there. Now, it's not going to make too much difference because you're going to rule out obstruction, as you'll see in every single case. So there it is. 3 rules. Exclude obstruction in every case. Now, why do we do this? Because if it's blockage and you relieve the blockage, that's it. The renal failure often goes away. You don't have to worry about dialysis, progression to chronic renal failure. I mean, that is an easy treatment. If there's a stone, and you can get them to pass that stone by fluids and lavaging it out, etc., you're going to reverse this right away. If there's BPH, benign prostatic hypertrophy, or prostatic cancer, put in a Foley catheter into the bladder. You've bypassed the obstruction. Bingo, the urine output increases dramatically. The creatinine will come right down. You should use radiologic tests to document this, to show that there's no blockage. This is essentially excluding this. There are 2 tests that are used all the time. Ultrasound, bouncing sound waves off the kidney, or a CAT scan. A CAT scan, again, you can do this without contrast. In renal failure, you don't like to use contrast because, again, that can produce problems itself. But essentially, you're showing that there's good flow of urine on both sides. And we'll look at this. In most cases, the ultrasound is fine. It is like sonar. I mean, it's like, think of the old TV movies with a submarine bouncing, and they look at the sonar thing and they look, for the other ships. Same thing. You're just bouncing sound waves off the kidneys, taking a picture of it. It's very fast, it's cheap, it's safe, it doesn't use contrast, so it's often the first thing we use. Now, one other rule that's important to realize, number 3, is unilateral obstruction does not cause progressive AKI. So why is that? Because you have the other kidney that's open. So yes, the creatinine will go up, but it's not going to keep going up to renal failure levels. So if you block off one ureter entirely with a stone, 100% blockage, what happens? The creatinine may go from 0.8 to 1 to 1.4 to 1.8, and then it'll stay there. That other kidney will take over part of the function of the kidney that's blocked. So again, you have to look for bilateral. So if you can show one kidney is open, one ureter is making urine, that's it. It's not obstruction that's causing the creatinine of 6 or 8 or 10. So this shows you normal anatomy here, okay, our normal ureters coming into and here's our ureteral orifices coming in, and here's our bladder and our urethra. Here, there's blockage at the uretero-pelvic junction, okay? This is a common source of blockage, actually, due to past stones in the past or congenital things. You get hydroureter and hydronephrosis. This kidney, if this is severe, will be making very little urine and contribute very little to the GFR. This kidney is normal. If this kidney is normal, your creatinine may be 1.82. It's not going to be 6, though. Here's our ultrasound. So here you're looking at the outline of the kidney. We're bouncing sound waves off the kidney. This is the normal cortex. If you're doing a biopsy, you want to biopsy this because that's where the glomeruli are and that's where the diagnosis is. This is the medulla of the kidney. You don't even see the collecting system, maybe little outpouchings like this. If you have somebody with benign prostatic hypertrophy and a creatinine of 4, because both ureters are blocked off, this is the collecting system, which has now ballooned out. The cortex is pressed down to a slight little rim around that. And again, putting a catheter into this person, this would come down. It would take months to come down to normal, but very often it does. So the ultrasound is very good for obstruction. It's also good for kidney stones. If you have a kidney stone on ultrasound, the sound waves are bouncing this way. They can't go through the stone. You see a sharp cutoff and a shadow behind it. Well, that's diagnostic of kidney stones. So you can pick up stones, you can see if there's blockage, and that's why the ultrasound is a good test. That's all you really have to know about obstructive uropathy and post-renal azotemia, unless you're going to become a urologist. If you're going to become a urologist, there are lots of other things you have to know, but I'm not going to teach them to you. Pre-renal azotemia, okay, very common. This is an oliguric condition. You have very little urine output. If you want a definition of oliguria, less than 400 cc's of urine per day. Okay, that would be typical, or less than 30 cc's an hour. That's oliguria, but there's scanty urine output. It's associated with a decreased glomerular filtration rate, like every form of AKI. It's caused by low blood flow to the kidney. 2 major causes. Volume depletion. You take somebody who has a GI bleed due to an ulcer. They become volume depleted. They have low blood flow, hypotension, low perfusion of the kidney. But volume overload does the same thing. Somebody with heart failure whose heart isn't pumping well will have the same problem. The heart won't be pumping well and the kidney sees low blood flow. The kidney is normal. The problem is that something is preventing the blood flow from going to the kidney, either hypotension or volume overload. Therefore, it's potentially rapidly reversible if you can correct the renal perfusion. So if you can increase the blood flow, you have the person who has the GI bleed, give them a blood transfusion, give them normal saline, you'll bring up their blood pressure. The BUN and creatinine, which were high, will come right down because it's reversible. If you have somebody who has bad heart failure, you can give them digoxin, you can give them milrinone, one of these inotropic agents that increases the pumping of the heart. The kidney will see better perfusion, the BUN creatinine will correct. So again, this is a correctable form due to decreased perfusion. Oops. So what happens in pre-renal azotemia? One thing is, because we know that the major thing is decreased renal perfusion, there is an increased filtration fraction. That is, the GFR is preserved a little better than the renal blood flow. That gives you increased proximal tubule sodium absorption. So you reabsorb a lot of the salt in the proximal tubule. We know with decreased renal perfusion, whether it's heart failure or volume depletion, the renin-angiotensin system is turned on, you have increased aldosterone, you get distal salt reabsorption. So we can expect that the urinary sodium is going to be very low because it's not we're measuring not what's reabsorbed, we're measuring what comes out in the urine. So to diagnose this, we get a urinary sodium concentration. It should be very low. The fractional excretion of sodium, that portion of the filtered sodium that's excreted in the final urine, expressed as a percent, is going to be low. Low sodium, low fractional excretion of sodium. So of the filtered sodium, not too much is coming out in the urine. The BUN is significantly higher than the creatinine in the blood. It's the ratio. They're both elevated. This is AKI. The creatinine has to be up or else it's not AKI. But if the creatinine is 1, instead of having a BUN that would be 10 or 15, the BUN would be significantly higher. So as the creatinine doubles, let's say the creatinine goes from 1 to 2. The BUN, instead of going from, let's say, 10 to 20, the BUN goes from 10 to 40. It's higher in proportion in the blood because urea back reabsorbs. It goes with the sodium and back reabsorbs. Thirdly, the tubules are normal. There's no damage to the tubules. It's prerenal azotemia. The problem is perfusion. So the osmolality is actually high. Now, you've already had the volume lectures in terms of this, so you know about ADH, antidiuretic hormone. Well, both volume depletion and heart failure give you a high ADH level. You have a lot of ADH, you have normal tubules, the urine osmolality, you'll reabsorb the water, you'll have a high urine osmolality. So you could look at the urine, sodium concentration, osmolality, and look at the blood, the BUN, and the creatinine and say, look, this person likely has prerenal azotemia. I'm going to correct the decreased perfusion, either giving them fluids, correcting the heart failure, etc. You'll look for one of those two things, volume overload or volume depletion. We're going to contrast that with the entity that we're spending the most time with this morning, ATN, acute tubular necrosis. This is the most common pattern of intrinsic ARF or AKI. It is a physiologic syndrome, even though there is morphology that we'll talk about that goes with it. Two major patterns, ischemic is low blood flow, and nephrotoxic. Now, we just said low blood flow and low perfusion gives you prerenal azotemia. If the blood pressure is low enough, long enough, what happens is that person goes from having prerenal azotemia to having ATN. And the pattern will be different in the urine, and the treatment will be different as well. So if you have somebody who has a drop in blood pressure, like Grandma Ida in the first slide, 73-year-old lady comes in with a blood pressure of 82/60. If she's had that blood pressure for a half an hour or an hour, that you can give her fluids and everything, you can correct the blood pressure, and her BUN and creatinine will come down. If she's had that for a couple of days, or if it was 50/40 or something very low, she'll develop ATN, and it will not be reversible by correcting the perfusion. You can correct the blood flow, but it won't make any difference. She'll still have tubular damage, and that creatinine will remain high. Now, we'll talk a little more about this. There are two patterns. The classic oliguric pattern, we said AKI usually has a low urine output, and in ATN, you have a low urine output, and then as you get better, the urine output progressively increases each day until it gets better. There is also a non-oliguric form of ATN, where the urine output never drops down. The pathophysiology is very similar. The markers in the urine are very similar, but you don't have the oliguria. Now, that's very important because it's harder to recognize. If the person keeps making urine and feels okay, you may not measure a creatinine. So the patient that I told you about, the 42-year-old who came in with cellulitis, that he happens to be immunosuppressed transplant patient, but he has cellulitis of his foot, gets a nephrotoxic antibiotic. They get 2 creatinines that are normal when he comes in, and they don't bother to check it for the next 2 days because the guy's making urine, he feels okay. They check it, all of a sudden his creatinine, which was 1 something, is now 4 something. Clearly, and his level of the antibiotic was toxic at that point. So again, non-oliguric is a little harder to recognize. So how do we diagnose ATN? You could look at the urine sediment. I know you've had a session on urine sediment. You could look at the urinary sediment. You would see these muddy brown granular casts. They're called ATN casts. A lot of people call them ATN casts. If you see lots of those in the urine sediment, it's suggestive of ATN. However, if you had low renal perfusion due to prerenal azotemia, you're going to get some of those casts anyway. So that's not the best way of diagnosing it. The best way is to look at the urinary findings. Here, the urinary sodium concentration is high, not low. The fractional excretion of sodium is high. It's over 1%, not less than 1%. Why is that? The tubules can't reabsorb sodium. In prerenal azotemia, they're avidly reabsorbing. Here, the tubules are all damaged, so they can't reabsorb sodium normally, so you get a high concentration in the urine and a high fractional excretion in the urine. The BUN and creatinine are both elevated, but the ratio is normal. There's no avid back reabsorption of urea. So if the creatinine went from 1 to 2, the BUN would be 20, 35. It would be, again, 10 to 15 times the creatinine. Remember, in prerenal azotemia, if your creatinine goes from 1 to 2, your BUN would be 40 or 60, much higher. The osmolality is fixed. Even if you have a lot of antidiuretic hormone, the tubules aren't working. They can't respond to it. They can't reabsorb the water, and therefore you get a urine osmolality around 300 milliosmoles per liter. If you do a little dipstick and look at the urine-specific gravity, it comes out 1.010 usually, or very close to it. So that's how we tell the difference between these two entities, ATN and prerenal azotemia. We use the urinary findings. Clearly, it's important. Prerenal azotemia, you're looking at how to change the perfusion to rapidly reverse the condition. In ATN, you're saying, look, I don't want to load this guy with fluid or anything. I want to give him as much fluid as he's putting out to keep him in balance. I want to check his chemistries to keep them in balance. And I want to consider dialysis if he needs it, if the numbers are bad enough. Non-oliguric ATN, again, we said, increasing incidence, common with nephrotoxins, especially nephrotoxic antibiotics. More difficult to diagnose because the patient doesn't complain of decreased urine output. It also has a lower morbidity and mortality, probably because it has different etiologies, and it's easier to handle if the patient is putting out a lot of urine. Now, what is the pathophysiology of ATN? What is the mechanism that goes on here? So there are a number of ischemic animal models where you drop the blood flow dramatically and severely in an animal, and there are a number of nephrotoxic models. Some that are things, that you'd never use in a patient. You wouldn't give a patient mercuric chloride or urinal nitrate, but we give them gentamicin. That's what happened in the first case there. Cisplatin, cyclosporin, vancomycin is what my patient in the hospital got. These are nephrotoxin. We know if we give them to animals in a big dose, they get renal failure. We use them all the time. Not all animal models have the same pathogenesis, and more than one mechanism may be going on. So when we think of this, think of the animal models. They're not perfect for human, and again, if you use a model that's not what's seen in humans at all, it may be totally different. Here's a question that if you spend your evenings and your nights staying awake thinking about ATN, one of the things that's going to come to your mind eventually is, why is the glomerular filtration rate low? This is acute tubular necrosis. The damage is to the tubules. We can see the damage to the tubules when we look at it. So why is the glomerular filtration rate low? Because we said the creatinine is going up, the BUN is going up. These are things that are filtered. There are 4 theories. There are more theories, but these are the 4 that have the best evidence. Vasoconstriction, back leak of tubular fluid, intratubular obstruction, altered glomerular permeability. Let's look at each of these. Oops. Well, we don't want to do that. Okay. So the first is vasoconstriction, and something is going on within the glomerulus, within the glomeruli and the vessels going to them, that is decreasing the blood flow severely. Now remember, we're talking about now about glomerular filtration rate. This is a normal kidney in an animal. you can make out the glomeruli here and the blood flow. Here you can see the vasa recti going down into the medulla. If you give a toxin to this animal that produces ATN, you can see the blood flow is markedly decreased, as are the vasa recti. 24 hours, it's worse. 48 hours, as the animal starts to recover, the blood flow starts to pick up again. And there are many different ways of measuring this. Early on in ATN, the blood flow is often decreased. In ischemic models, it's always decreased because that's how you're producing it. A lot of thought has gone into the fact that it may be hormonal, that something is going on right at the level of the glomerulus that's turning off filtration. We know from early studies the juxtaglomerular apparatus is hyperplastic in patients and animal models that have ATN. There are increased levels of renin and angiotensin II. There are experiments with blockers of the system, and there's good evidence for a mechanism called tubuloglomerular feedback, which I'm going to explain now. Now, the renin-angiotensin system, which I think you've had already with volume, but you're going to have it again probably in the next lecture on hypertension, and certainly when they talk about antihypertensives. Some of our best antihypertensives are blockers of the conversion of angiotensin I to angiotensin II, which is a very potent vasoconstrictor. Others are receptor blockers of the system. In any case, the thought is that this system may be acting locally right at the glomerulus. If I ask you why the kidney is different from every other organ, I am sure we'll get some very interesting answers. Probably half the class usually says because the kidney makes urine and no other organ makes urine. That's true. It is the only place in the body where you go from arteriole, capillaries, arteriole. Every place else is arteriole, capillaries, venule. So that's very important. When you'll talk about this with blood pressure, what you can do by changing the flow in this efferent arteriole. But if there's local stimulation of the renin-angiotensin system, you may be able, normally we think of angiotensin II as squeezing down here on the efferent arteriole. But if you locally produced a lot, you might be able to squeeze down on both of these and cut off the blood flow to that glomerulus entirely. Here you can see glomerulus, afferent arteriole going in, efferent coming out. Same thing, every glomerulus. If you look at a glomerulus, this is again the globe cut cross-section. Here's an afferent and an efferent arteriole. I don't know which is which. Here's the juxtaglomerular apparatus. Now, another unique thing about the kidney is the way the tubules are arranged. Here's our glomerular filter, proximal tubule, loop of Henle, etc. Every single glomerulus has the distal tubule coming right back at the afferent arteriole here. The distal tubule comes right back here, actually between the afferent and efferent arteriole. Now, that could be a coincidence, and either we evolved that way, or if you're into religion, God made it that way. It's unlikely to be a coincidence. That I can tell you. I mean, that no matter which theory you believe on, there's a reason for this. Increased delivery of chloride, not sodium, but it's chloride here, which comes with sodium chloride, to the macula densa here of the distal tubule leads to vasoconstriction of the afferent arteriole. So if you have damage to the tubule and you're not reabsorbing sodium chloride, a lot of it comes down here to the distal tubule. That causes vasoconstriction here at the afferent arteriole, not just the efferent, but the afferent, and you cut off flow. And a lot of people think this is angiotensin II, but there's a whole bunch of vasoconstrictors it could be. This is tubuloglomerular feedback, the same tubule, that huge amount of salt, sodium chloride. Some people have called it acute renal success, because if you kept losing a lot of salt at sodium chloride here and you weren't absorbing any, you'd volume deplete yourself in no time. In a matter of hours, you'd be totally dried out to nothing, maybe even less than hours that day. So here you have to shut down that glomerulus filtration if you're not reabsorbing anything. Oops. Another theory is back leak of tubular fluid. You have, normally, things are filtered, inulin, creatinine, they come out in the urine. They're not reabsorbed. If you have damage to the tubules, they get back reabsorbed right across the tubules. This just shows you what happens if you inject labeled tritium into a normal animal and you micropuncture it into the proximal tubule and just collect the urine from that ureter. It's all going to come out. You'll get almost 100% of what you injected. If you inject it into an animal that has ATN and damage, you only collect 17% of everything else gets reperfused, it gets reabsorbed, and it comes out on the other side. So again, there is evidence for back leak. Obstruction. If you look at ATN due to many different causes, there are casts that fill. Here's our slough tubular cells, and here are casts. They just fill the lumen here. Again, it's obvious that this might cause blockage to the tubule. You only have to block the tubule one place to turn off glomerular filtration rate. So here, the obstructing cast gives you increased pressure. When it matches the pressure in the glomerular filter, you turn off perfusion. And there is evidence in animals that the pressure in the tubules goes way up in the beginning of ATN. So we had three theories: vasoconstriction of the afferent arteriole, obstruction, and back leak of fluid. There's one more theory: altered glomerular permeability. Here, the problem is right at the glomerulus, that the glomerulus is just not filtering well, and therefore the GFR is down. Here's a normal glomerulus. You're looking at capillary loops. You're sitting in Bowman space. Here's the visceral epithelial cell. Here are the loops. We'll be doing a lot of this with glomerular disease. Here's a urinal nitrate model of ATN in an animal. You can see the whole glomerular capillary wall looks markedly abnormal. It's easy to understand how you would have a problem there. So we said you start with an ischemic insult or nephrotoxic, a nephrotoxic antibiotic, contrast, etc. You may have reduced renal blood flow, modifying hormones of the renin-angiotensin system at a local level. You get vasoconstriction, back leak, tubular obstruction, decreased permeability. Some combination may be important in a certain model. Some combination may be important in a different model. It may be one factor more than another. Each of these will add up to, again, giving you that decreased glomerular filtration rate. Now, let's turn from the decreased GFR, because some of you may stay awake at night not worrying why the GFR is down, but you may be saying, well, what's happening to the tubules? If it's ATN, what's going inside those tubules right now? And here you can see that there's no brush border on these cells, etc. So if you look at an early phase of ATN, the mitochondria of the proximal tubule, here's our brush border, here's our cells. The mitochondria start to round up here, their cristae start to get abnormal. Later on, you lose the brush border of some of the cells. You can see these whirl-like myelin figures here. And then the whole thing is just totally destroyed and everything gets sloughed into the lumen. If you look at a biochemical level, we know the mitochondria are whacked out. They have decreased oxygen, basal and maximal oxygen consumption. We know that reactive oxygen species are increased, phospholipases are activated. Cellular potassium is low, cellular calcium goes up, and especially in compartments where it shouldn't be, and you lose your high energy phosphate bonds, ATP. This shows you a P32 NMR of a normal kidney. This is the beta peak of ATP. It's very specific, so that tells you how much ATP is in that kidney. Here's an animal kidney. You're causing ischemia by clamping the kidney. Here's the peak. 7 minutes after ischemia, it's gone. 45 minutes, it's still gone. You release the clamp, ATP levels go back up. So again, we know some of the biochemical evidence that's going on. So here we think the two models, ischemic and nephrotoxic, reduce ATP and ADP. You have inability to regulate your intracellular ions. That is, the sodium goes up, the potassium goes down, the calcium's in the wrong places. Calcium activates lipases here. You get reactive oxygen species, mitochondrial damage, and eventually organellar damage, and the cell dies. Now, the other thing that's important is that if you look at cells in general in ATN, remember the proximal tubular cells have a brush border and they have ATP on the basal and lateral surfaces. These are sodium-potassium ATPases. They lose polarity in ATN. They don't have a brush border, and the sodium-potassium ATPase is now found here on the luminal side. They get necrosis, apoptosis, cell death, eventually with sloughing of cells. Eventually you get migration, differentiation of cells, back to proliferation, and you reestablish everything normal, and the patient recovers, hopefully. There's a lot of work going on with stem cells. Unfortunately, at this point, stem cells have not proven the panacea that we thought they were. We've done we've done trials here using stem cells in people undergoing bypass surgery where there's a high incidence of ATN, infusing stem cells to try to prevent it. Hasn't worked. So don't think we're the only people. This was a combined Harvard-Columbia study. It didn't work at Harvard either. So, but still, this is where a lot of the work is going. The other thing that's important to realize that we have new markers that tell us the person is going into ATN. NGAL and KIM-1 are both markers that are turning out to be successful. NGAL stands for neutrophil gelatinase-associated lipocalin. That's the reason we say NGAL, because nobody wants to say that. Kidney injury molecule is KIM-1. But you can see in the urine and the plasma, NGAL goes up after bypass surgery. It goes up after contrast nephropathy. It goes up before the creatinine goes up. It's much more sensitive. KIM-1 does too, but let me show you here. Here's NGAL work, because again, a lot of this work is done by, here's John Barash's name, and you'll see Tom Nicholas's name in here. So here you're looking at urinary NGAL in 20 patients who developed ATN, 51 patients who didn't. You can see it goes up early. Here's the rise in creatinine. It's hours before. You can diagnose this earlier. So this could be the test that we need for the future to get this back here and know what's going on before we have to wait 24, 48 hours. Here's AKI. Now, this is AKI of the ATN type. Here's prerenal azotemia. It doesn't go up. Chronic kidney disease, it doesn't go up. Normal kidney function, it doesn't. So again, this could be a valuable marker. It's got to be more validated in much larger series, but this is what people are looking at. And again, here's Tom's name and a bunch of other people from our institution. What happened to those 4,600 patients who had AKI? Partial recovery, 23%. Discharged with an increased creatinine, 17%, like my patient who just went home, but I'll see him as an outpatient. Discharged on chronic hemodialysis, 3%. Died, 20%. The good thing is we have dialysis. You'll have a lecture on chronic renal failure, and it'll talk about dialysis. Essentially, it can correct the internal environment, correct the electrolytes, the volume overload. We can take off fluid, and we can keep people alive so they survive the ATN. The difference, the huge difference between World War II and the Korean War in terms of saving lives was that they already knew about dialysis. But by the time the Vietnam War came out, all of these people who were going into shock and everything, dialysis was almost routine for them. And now you can save many more sick people in terms of this, whether it's in war or after a myocardial infarction, by dialyzing them. So what happened to our patient here? She got dialyzed, and she recovered. This is a very common condition, high morbidity, high mortality, different causes, pre-renal, intrinsic, and post-renal. The diagnosis depends on understanding the pathophysiology and doing the correct tests. ATN, nephrotoxins and ischemia. We've got better biomarkers coming out. NGAL, KIM-1 are at the top here now. We do need better therapies for once you're in ATN, but that'll come as we get better markers and have a better understanding of the pathophysiology. So I'm going to stop now. Thank you. I'll be happy to take any multiple choice questions down here.
question about some of the mechanisms you were talking about at ATN, particularly reconciling the second one, the backflow in the tubules, with the first one, which is increased delivery of chloride. So if you have increased permeability in the tubules, wouldn't you lose chloride?
So it would be hard to say both mechanisms are going on at the same time in a given model. You might have one in one model, like you could have backflow and obstruction. You could have decreased permeability and one of them invasive. But it's hard to so that's the problem. Now, what's happened is that the people have bypassed a lot of this because they say, well, look, it is important to know why the GFR is down, but we haven't figured out a way to get it better. So almost all the studies are empiric, and now, especially with stem cells, more and more effort trying to correct the defect once it's there. But the animal model stuff, the problem is, you say, well, why is the GFR down? Why is the creatinine going up if this is tubular damage? I mean, if you just think about ATN, you've got to ask yourself that question.
So with the second one, with the decrease or the increased permeability in the proximal tubule, that's what it is.
The increased the back leak is, it's just damage to the tubular cells and the fluid just goes back.
So it goes into the tubule
and then gets reabsorbed. You reabsorb it into and recirculate it. Remember, if you inject into the proximal tubule, you get very little coming out of that ureter. It all gets recirculated, comes out the other ureter from the good kidney.
Okay.
That is ischemic or nephrotoxic. Either those are the two big mechanisms. Right.
I also have a question too. You see allies. Why you choose allies immediately to form that ATN?
They've done studies on that. Early dialysis. They wouldn't do it immediately, but they would often do it early on in terms of the course. Early dialysis doesn't seem to make a difference.
They gave him a mic.
It doesn't
They gave
seem
him a
to,
mic.
because it's like my patient, the 45-year-old. So he's got an elevated creatinine. He's just going to go home.
Your mic's still on.
What's that?
Your mic is still on.
Oh, I'm advertising. It's a good thing I didn't know.
Or an advancer?
There's no point. The advancer, you can use.
Just use the mouse. But there was no remote.
There's no remote.
So you pretty much have to stay up here anyway.
Yes, you do. But you can use this if you want. And
You can
and you can use this. This will also go up and down.
Oh, okay.
Yeah. So,
This is
I don't know if you can do it
Do we start at 10:05 or 10? Do I start at 10:05 or 10? Do we start at 10:05 or 10?
Depends how long it's your call.
About 45, 50 minutes. I just basically I just say call to order, write down numbers. Yeah, I probably have to rewrite this out.
Yeah, I'll send you the
I have it already. I have one. Like the one that one wrote? Yeah, I mean, it's actually not bad. I actually thought it's not a bad idea that it sort of complements his talk, but it's not exactly. My talk is different from his talk. I got rid of some of his sort of. I got rid of some of his more like old animal experiment stuff to kind of make it more clinical. Yeah. Yeah. I'll rewrite it down. Okay, we're going to try to get started so that you all can go to your small groups exactly at 11, so that you can all leave your small groups exactly at 11:55 and go to today's very exciting medical grand rounds, which is about the kidney. My name is Andy Bombach. I'm one of the nephrologists here. It is yes, my name is Andy, and it's a real pleasure to talk to you guys today about blood pressure. Blood pressure is an incredibly common condition. If you're a doctor and you're not seeing hypertension, then you're probably not actually seeing patients. So you will always be seeing hypertension in your patients. And what we're going to do today is we'll start by doing just some basic review of the epidemiology of hypertension, and we'll go over the consequences of uncontrolled hypertension. And we'll try to get through that pretty quickly so that we can spend the majority of the next 45 minutes or so going over some of the theories as to why people become hypertensive. You know, the truth of the matter is that most of the times when patients ask us, well, why do I have high blood pressure? We don't give them an answer. We just say, well, we don't know. It just runs in your family. So what I'm going to try to do is give you some theories as to why people become hypertensive. And what we're talking about today is what's called primary or essential hypertension, which is about 95% of hypertension. This is different from what you'll hear about tomorrow from Dr. Garavi and Dr. Newhouse, which is called genetic or secondary hypertension. These are rare forms of hypertension where, as a doctor, you can sound very smart and say, you have hypertension because of reason X or reason Y. Finally, by the end of the talk, you will hopefully have a working theory of why people become hypertensive. And with that working theory of why someone becomes hypertensive, you'll have a rationale for why we use specific antihypertensive therapies. And then tomorrow you'll get a talk from Dr. Radhakrishnan about those specific antihypertensive therapies. So I'm basically priming you so that tomorrow you'll be very set up for the talks. So we've actually come a long way in terms of how we approach hypertension. This is less than 100 years ago in one of the top medical journals where a physician said, don't lower blood pressure. If blood pressure's up, it's just the body's physiologic response. It's trying to perfuse organs. Let it go as high as you want, and if you lower it, you're an idiot. So it turns out that he was the idiot, that you actually shouldn't let blood pressure go uncontrolled. And it actually wasn't doctors who first noticed this. It was the insurance companies. So life insurance companies kept incredibly detailed records on their patients, including all their medical records, and they wanted to know who was the best person to give life insurance to, who would basically live the longest, pay their yearly premium, and not have to get the payout of the life insurance. And what it showed them was that if you had normal blood pressure, which they defined as less than 130/90, you would live the longest. So let's sign these people up for life insurance. Whereas if people had higher blood pressures, and as the blood pressure goes up, they saw a reduction in life years. And so they basically said, well, having high blood pressure clearly is a dangerous thing. So the life insurance companies knew this. They kept very nice records which showed that there was this linear and then it became almost asymptotic relationship that as blood pressure rose, the rates of death rose, and these are early deaths. And this is diastolic, but you can make the exact same type of curve with systolic. What they didn't show, which is important to know, is that this curve is not a perfect line down. It actually is more like a U-shaped. And one of the things that we've learned as doctors, as we've become a little bit overzealous in treating high blood pressure, is that you don't want to overtreat. Low is good, but lower is not better. So there's sort of a sweet spot at the bottom of a U that you're trying to treat patients to get them to an optimal blood pressure. And this goes for both systolic and diastolic. As I mentioned, high blood pressure is incredibly common. This slide, which I didn't make that long ago, is already outdated. It's more than this number, but essentially more than 75 million Americans have high blood pressure. More than 1 billion people worldwide have blood pressure. The prevalence of high blood pressure is increasing. It's increasing for a number of reasons, but two of the most common reasons why it's increasing is that as a population, we are getting fatter and we are getting older. And so obesity is driving much of the hypertension, and age is driving much of the hypertension. What we know now from those life insurance studies, but also from very well done medical studies, is that if you lower blood pressure, you do see good outcomes. You reduce the incidence of coronary events, you reduce the incidence of strokes, there's less prevalence of congestive heart failure, and from a kidney standpoint, which is really the only thing that's important, you see less kidney failure, less people going to end-stage renal disease. And yet, we know all this, but if you look at people with hypertension, up to about 2/3 of them are not controlled. Now, tomorrow you're going to be hearing about a lot of drugs, some better than others, and you'll hear about the mechanisms of how these drugs work, and you might say, well, that's a great drug. I'm going to use that drug because I love the mechanism. And that is a very important thing to think about, but nothing trumps getting the patient to a goal blood pressure. So doctors have also done very nice studies showing that the risk of high blood pressure increases as blood pressure goes up. This is from the Framingham Heart Study. Optimal blood pressure in this study. Now, this is not treated with blood pressure medicines. This is just natural blood pressure. Blood pressure less than 120/80 was deemed optimal, and you had the longest life expectancy. In this study, it was 83 years in men, 87 years in women. But as blood pressure rises, you see an increased risk for cardiovascular disease and a decreased overall survival. So again, our epidemiologic studies confirm what 100 years ago the insurance companies were saying: the lower the blood pressure, the better, especially if it's untreated blood pressure. So that's the best case situation. So I would hope all of you guys are in your 20s and you're exercising and eating very healthily, that your natural blood pressures are in this less than 120 over less than 80. But what I will tell you, we used to have this thing when you started med school. They said, look to the left, look to the right. One of you is going to fail out. Now that doesn't happen because we want your tuition money. But what is true is if you look to the left and look to the right, certainly one of you will have high blood pressure during your lifetime. And you don't even need to look to the left, look to the right. I would bet a lot of money that all of you have family members with high blood pressure. It's an incredibly common problem. One of the things that I mentioned earlier is that as you age, you become more likely to have hypertension. And that's part of the reason why we're seeing more hypertension. It's natural for your systolic blood pressure to rise if you're a man or a woman, and it continually rises. But in around the mid-50s range, the diastolic pressure tends to fall. Why this is happening, we think, is due to changes in systemic vascular resistance, which, as you'll learn in a coming slide, is one of the main components of your blood pressure. But this actually sets up an interesting pattern where the systolic is elevated, but the diastolic is normal. And this is a pattern that we call the isolated systolic hypertension of the elderly. And this becomes somewhat of a tricky problem for the treating physician because you are potentially running the risk of over-treating the systolic at the detriment of the diastolic. And so as you'll see, one of the changes that's come into the guidelines is we've relaxed the goal blood pressures as patients get older, and we're labeling less and less older individuals hypertensive. But this is important to know that you'll start to see elevations in blood pressure starting around the time, right around your age. Okay? So you're not immortal. As you start to age, you start to raise your systolic blood pressure, and your diastolic's going up, and then right around the mid-50s, it starts to drop. We have guidelines as to what good blood pressure is. The American guidelines are called JNC, and the last official JNC guidelines were about 12 years ago, called JNC 7, where they said normal blood pressure was less than 120/80. You see, these are very similar to the data that was come out of the Framingham Heart Study showing what pre-hypertensive is and then hypertension starting, all about increased risk for cardiovascular morbidity and mortality. If you use those JNC 7 guidelines, and this data now is a few years old, about 70 million Americans have hypertension, and again, more than half of them are uncontrolled. And actually, what's even more disturbing is that the vast majority of those uncontrolled hypertensive patients don't even know that they have hypertension. Now, there were new guidelines that came out last year. We call these JNC 8, but they're actually officially called the 2014 Hypertension Guidelines. And the big change was that they recognized that isolated systolic hypertension pattern in the elderly. Now, people in this room will probably be upset with how they defined elderly. But they were basically going on the idea of where that inflection point is with the diastolic curve. And so they said if you're less than 60, the goal blood pressure should be less than 140/90. If you're older than 60, the goal blood pressure should be less than 150/90 to try to avoid over-treatment of the systolic at the detriment of the diastolic. When they relaxed those guidelines, all of a sudden it looked like we were doing a lot better. So using the old guidelines, only about 40% of people had blood pressure controlled. With the new guidelines, this goes up to about 57%. So that's great. I mean, I wish I could just write a manifesto and all of a sudden my job performance would go up. That would be great. But, you know, the true thing is that this is still bad. So over 40% of hypertensives, even with these new relaxed guidelines, are still not at goal. And so we still have a lot of work to do to get blood pressure better controlled. This paper just came out in the New England Journal. If you notice, the last author is your dean. So that means this will definitely be on your test. So what the dean did, I'm sure he did some of the work, but my guess is that Dr. Moran, who's a Columbia doctor, did more of the work. But essentially what they did was they predicted that if you took that 42% of patients who are uncontrolled and you got them to meet those 2014 hypertension guidelines, if you basically got those 42% of patients now controlled, they were able to predict that you'd see 56,000 fewer cardiovascular events per year and 13,000 fewer deaths from cardiovascular causes per year. That is a huge public health impact. So you guys are going to be on the front lines in a couple of years. This is one of your charges, to get people better controlled with their high blood pressure. If you don't control the blood pressure, this is what happens. These are autopsies. Okay? These are not samples taken from patients who are alive. Patients are dying of massive strokes, of massive cardiomegaly and heart failure, and from a kidney standpoint, they're dying of renal failure. And hypertension is the second leading cause of kidney failure. Over 30,000 new cases of kidney failure every year due to hypertension. Sometimes we biopsy patients with hypertensive kidney disease. We generally are not suspecting that hypertension is the only problem. We're worried about something else. But if we do see a kidney where the main lesion is hypertensive nephrosclerosis, the big finding is in the vessels. So this lumen should be wide open. It should be nice and open to allow perfusion of the kidney, and instead it's being completely occluded or near completely occluded by intimal thickness. And it's really a reduplication of the internal elastic lamina, and in essence you're getting arteriolar hyalinosis building up in the vessel, shutting off the lumen as opposed to a nice healthy lumen that's wide open. You also start to see tubular atrophy as the kidney is dying off. There might be an error in the arrow in your slides. The arrow should be here. I think it was put over there, but this is arteriolar hyalinosis. So that's about it that I'm going to talk about the epidemiology and the consequences of hypertension, because that to me is a little bit dry as I drink water. But instead what I'm going to focus more on is why people become hypertensive. Now, if you're in my small group, we made a little joke yesterday that we should never try to answer a question that starts with why, because that's really religion, and we should always be talking about how. So I probably should just change this to how we develop hypertension. But the slide's already made. What we're really talking about here is this type of hypertension that's called primary hypertension. Again, not the secondary types that you'll hear from Dr. Garavi and Dr. Newhouse tomorrow. Those are rare causes of hypertension. They may be due to genetics. They may be due to hormone-producing tumors. I like to call those identifiable hypertension because you can identify the cause, you can correct the cause, and all of a sudden blood pressure should go away. But what we're talking about here is unidentifiable hypertension. More than 95% of the hypertensive patients you'll see have this type of unidentifiable hypertension. And you generally tell the patient, we don't know why you're hypertensive. It's probably something with your genes or something in the environment that's making you become hypertensive, but we can't point to one distinct entity. Now, before you say that to the patient, you want to make sure they truly have hypertension. So just one office visit does not make somebody hypertensive. You want to repeat blood pressure at least 2 other clinic visits. And now with technology, what we're doing far more often is asking them to check their blood pressure at home. Go to Walmart, go to CVS, get a $30 blood pressure cuff, check your blood pressure at home. The home blood pressure is a much more accurate measurement of blood pressure than the office pressure. You probably have heard of something called white coat hypertension, where patients go into the office, they see a white coat, their blood pressure goes up. At home, it's much lower. There's also the flip phenomenon called masked hypertension, where home is really stressful and their blood pressure is really high, and then they come into the office and it's nice and quiet and their blood pressure goes down. And about 30 to 40% of people, the clinic blood pressure is not indicative of what their home pressure is. And we like the home pressure as the more accurate assessment of what their true blood pressure is. The newer thing that we're doing now, this has been done in Europe for ages, but now finally we're doing in America, is 24-hour ambulatory blood pressure monitoring, where patients just wear a continuous monitor and they check their blood pressure throughout the day and we get a readout of their average daily blood pressure. So as we start to get into the physiology of blood pressure, what is blood pressure actually composed of? How does our blood pressure even originate? Well, it's the product of cardiac output and systemic vascular resistance. And so let's just break up those two terms. Cardiac output, in turn, is the product of myocardial work and cardiac return. And cardiac output really stems back to volume. And you're going to hear me talk about volume for the rest of the talk. Because as a nephrologist, when I view blood pressure, I'm pretty much viewing it primarily from a volume standpoint. Because volume is what determines your cardiac output. Right? Your venous return is essentially what's going to determine your cardiac output, assuming function is normal, assuming ejection fraction is normal. So volume is the main determinant of cardiac output. And then systemic vascular resistance, which is essentially your vascular tone, which is mediated by vasoconstrictors and vasodilators. These are hormones you've been hearing about in the last week, things like angiotensin II and vasopressin that vasoconstrict, things like AMP that vasodilate. Well, what is the stimuli to those hormones? Volume. I mean, volume remains the main stimulus to that. So as we start going through now some working theories of hypertension, it's all about volume. And as you know from small group yesterday, when we talk about volume, what we're really talking about is salt. Salt balance, how your kidney regulates your salt balance. Is it able to keep you in a salt steady state, or are you building up a salt load, or are you excreting a salt deficit? And so we're going to go through now 3 working theories, what I call working theories or hypotheses, as to why people become hypertensive. Why our genes or why our environment make us hypertensive. And the first theory that I want to give you is called a salt excreting handicap. And the word for salt excretion that we use that sounds fancy is natriuresis, so a natriuretic handicap, some defect in the way your body is excreting salt. And this, in turn, is called the pressure natriuresis theory. I wish this theory was invented by a nephrologist, but it turns out if you go to the books, the guy who came up with this was a cardiologist. So we make him an honorary nephrologist. So let's use an example. This is sort of similar to what you talked about yesterday in small group, of a kid who's in high school, comes home from school, and then goes to the pizza place and gets like 9 slices of pepperoni pizza and 5 bags of Lay's potato chips, and then drinks a lot of soda. So what's going to happen to that kid? Eventually, well, if it's, the case from yesterday, if he's eating that every day, nothing's going to happen. But even if he's not used to eating that tremendous amount of a salt load, he's just going to basically reestablish salt balance within a day or 2, right? So we said that the kid who gained 1 kilogram, he's just basically going to reestablish salt balance in another day or 2 because his kidneys are going to be able to compensate that salt load. He'll very quickly get rid of that extra salt load. If the kid grabs his grandfather on the way to the pizza place, his 80-year-old grandfather, and makes his grandfather come to the pizzeria with him, and if for some reason, this little sadistic kid, he forces his grandfather to match him slice for slice, pepperoni for pepperoni, Lay's potato chip for Lay's potato chip. Even if the grandfather just came back from the doctor's office and was reassured, everything looks great, your blood pressure is great, you have, very nice looking kidney function, the grandfather's going to be in trouble. And the reason why is that the grandfather's kidney is just not as good as the grandson's kidney. There's an age-related decline in kidney function. And so the grandfather is going to fall into a much higher salt overload state than the grandson. And the kidney is not going to be able to accommodate very quickly. So what are you going to do in that situation? You're now in a positive salt balance, and you have to reestablish salt balance. So the quickest way that the body will try to reestablish salt balance is to increase the filtration of the salt. And it does so by increasing pressure. So blood pressure will go up systemically so that you increase the hydrostatic pressure so that you can filter out more sodium and reestablish salt balance. And this is what pressure natriuresis says. If you are facing a salt excreting deficit or a salt excreting handicap, and your kidney cannot get rid of a salt load, the way the body responds is to systemically raise blood pressure so that you can filter out more sodium and then reestablish salt balance. That sounds good, except for the fact that all this is done at the cost of being hypertensive. So if you're chronically facing an excess salt load that your kidney cannot accommodate, if you chronically have a salt excreting deficit that you can't get rid of all the salt that you're eating, your body responds by raising blood pressure to allow you to reestablish salt balance, but at a higher blood pressure. And so that is what the pressure natriuresis theory is. It says that most essential hypertensives have some defect in the level of the nephron that's making them not handle salt loads. Now, this can be an obvious defect. So if you have a patient who comes to your clinic and has chronic kidney disease with a GFR of 30, well, of course they're going to have a salt excreting defect because their kidney's only working about 30%. So that's not surprising. But many essential hypertensives, the salt excreting defect is what I call a colt. They have perfectly normal labs, and yet they're hypertensive. And when they ask me, why are you hypertensive, I have to say, well, my theory is that even though it looks from the blood work that you have excellent GFR and your kidneys are working fine, I think somewhere along the nephron there's some defect in the way your kidney is handling salt loads. And you're not getting rid of salt efficiently, you're slowly building up a salt overload, and your body's trying to reestablish balance by raising blood pressure so that you can filter out the excess salt. And that's why, when we start to treat these patients, we rely heavily on salt restriction in the diet and diuretics with our medications to help them get rid of that salt that their kidney's not able to get rid of. And so the simplest way to phrase this, which is something that we say all the time, is blood pressure follows the kidney. If you have good kidney function, you should have a good blood pressure. If you have bad kidney function, you will have a bad blood pressure. But it's even more precise than kidney function. If your kidney is good at handling salt loads, if your kidney can excrete sodium well, you will have a good blood pressure. If your kidney cannot accommodate salt loads, if your kidney cannot excrete sodium well, you will have a bad blood pressure. This has been shown beautifully in rat experiments. So if you take a genetically hypertensive prone rat, what's called the SHR, the spontaneously hypertensive rat, and you transplant its kidney, take its kidney out and give it to a genetically normotensive rat, what's called the Wistar-Kyoto rat, this rat will become hypertensive. If you do the reverse experiment, if you take a normotensive rat's kidney and transplant it out and give it to a genetically hypertensive prone rat, this rat will become normotensive. Blood pressure follows the kidney, and it's specifically following the kidney's ability to handle salt loads. Now, we treat humans, but we do this experiment all the time in the hospital. So I'm sure today there's 1 or 2 kidney transplants occurring, and this is exactly what we do with the kidney transplant. We take an older individual with end-stage renal disease, kidney failure due to high blood pressure, comes into the hospital on 5 antihypertensive medications. He gets a kidney from a young, healthy donor with excellent kidney function. Assuming the kidney works, that there's no rejection of the kidney, it would not be surprising for a week later this guy to be completely off antihypertensive medications, to go from being on 5 meds in kidney failure to having good kidney function and being on no antihypertensive meds. That's blood pressure following the kidney. We know this in nephrology because when we go to our patients, they all have bad blood pressure. So they all have bad kidneys, they all have bad blood pressure. If you look at the prevalence of resistant hypertension, which is defined as having a blood pressure above 140/90, despite being on 3 or more medications for blood pressure, over half the people in nephrology clinics meet that definition. So If I'm meeting a patient, the chances are that patient will be on 3 or more medications and have blood pressure above goal because their kidney function is poor. If you go to just a regular general medical practice, it's much lower, 5 to 15%. So that's very clearly blood pressure following the kidney. And that's why if you go to our nephrology clinics with us and we see a patient with resistant hypertension, our first line of medication therapy is to start a diuretic. And if they're already on a diuretic, we just increase the dose because we know that if they're hypertensive, they're just not getting over that salt excreting handicap in their kidney. An extreme version of this is in patients who are on dialysis, patients with complete end-stage renal disease and no kidney function. Because in that case, we use the dialysis machine to do the work of the kidney. And you're going to get a whole dialysis lecture, but I'm just going to briefly tell you that when we do dialysis, one of the things we do is we remove fluid. We basically do the body's job of removing salt and water. We do it with the dialysis machine. And we can actually set the machine to say, I want to remove 2 liters, I want to remove 3 liters, I want to remove 4 liters. And if you do that, if you ramp up the amount of fluid that you remove from a patient, if you do 2 liters, for example, and then go to 5 liters, well, you're removing more salt and water, blood pressure is going to drop, systolic and diastolic. But this is an extreme example of blood pressure following the kidney. It's just that the kidney, in this case, is a dialysis machine. But more ultrafiltration, more removal of salt and water, blood pressure drops. So the better you ramp up the dialysis machine, the more blood pressure reduction you'll see. And this is why, of all the antihypertensive therapies that we deal with, nothing trumps salt restriction. Salt restriction is by far the most natural way to overcome a salt excreting handicap. You know, if your kidney can't get rid of salt, well, the quickest thing to do is get rid of salt. Like if I can't deal with John, I just say, John, get out of the room. Right? So essentially, this is the quickest way to deal with the problem. And it's the most effective. So if you take patients with very bad blood pressure in the 160s over 90s range and go from about 6 grams a day of salt, which I would bet is what everybody here eats on an average basis, and go down to a low salt diet, blood pressure becomes optimally controlled. And actually, one of the beautiful things about salt restriction is that the worse your blood pressure is, the more sensitive it is to high blood pressure. So if you take people who don't have any hypertension and you put them on a low salt diet, they barely drop their blood pressure, 2 over 1. But if you take the worst hypertensives and you put them on that same salt restricted diet, they drop by about 20 over 10. What that tells me is that the worse the hypertension is, the more severe the salt excreting handicap is. The more severe the deficit in the nephron is at handling salt loads. And that's why salt restriction becomes more and more effective. Okay, so we're going to move on now to the second working theory of hypertension. You'll see these theories complement each other because they're all about volume and they're all about salt. And the next theory is what I call the thirsty gene hypothesis. So you probably have heard in the news about the thrifty gene hypothesis, right? It's the explanation for why so many people are obese. Because we evolved from ancestors who weren't around an unlimited supply of food. They had genes that allowed them to maximally take all the calories out of food because it was so scarce. And if you take those genes and now put them in the McDonald's world of today, where food is everywhere and you can get food all the time, you're going to basically become obese because of those maladaptive genes. So that's the thrifty gene hypothesis, which I'm sure you've heard about. What I'm talking about here is the thirsty gene hypothesis. And what the thirsty gene hypothesis suggests is very similarly to the thrifty gene hypothesis, that there were genes that we developed in our ancestors because they weren't exposed to a lot of salt. And those genes become maladaptive in the setting of salt. Our ancestors developed genes that had them maximally reabsorb sodium. And we now, if we take those genes that tell us to maximally reabsorb sodium and put that into a high salt milieu, into McDonald's, that's going to be problematic. And one of the ways to think about this is to think about some of the drugs that we use to treat antihypertensive therapies. So you heard a little bit from Dr. Appel, and you'll hear a lot tomorrow from Dr. Radhakrishnan about blocking the renin-angiotensin-aldosterone system using drugs called ACE inhibitors and angiotensin receptor blockers. And it's interesting to think about where these drugs were developed. So it turns out that captopril, which is the first ACE inhibitor to be developed, actually was developed out of the venom of the Brazilian pit viper, Bothrops jararaca. And one of the questions that I would ask is, well, why would a snake have captopril in its venom? Like, why would a snake have a renin-angiotensin-aldosterone system blocking agent in its venom? And so if you're trying to figure out why that is, you would figure out, well, who's the snake going to bite? Like, who is the snake trying to kill? And so an example of the prey of the snake are the Yanomamo tribe of South America. Is anybody here an anthropology major in college? Do you guys ever hear of this tribe? All right, well, go back to your professors. So, well, essentially, this tribe was extensively studied by anthropologists in the 70s. And they were studied specifically because they were deemed the perfect example of a primitive low-salt culture. They had not been westernized at all. They were hunter-gatherers. They ate what they killed. They didn't use any salt to preserve foods. They ate extremely small amounts of salt, about 500 milligrams of sodium a day. And again, just to sort of compare that to what you guys eat about 6 to 8 grams of sodium a day. So they were extremely low-salt consumers. They relied on the renin-angiotensin-aldosterone system to maintain just normal tension. When they looked at their blood pressures were fantastic. These were like 20-year-old marathon runner blood pressures that they were finding in 50 and 60-year-olds. 90s to 100s, over 50s to 60s on no medications. And when they measured the components of the renin-angiotensin-aldosterone system, they measured renin activity, they measured aldosterone. These levels are more than 6 times the upper limit of normal that our labs report. So if you sent a patient for aldosterone and renin profiling in our lab, and these levels came out, you would get a page from our lab saying, we either made a drastic error or your patient is severely hyperrenin, severely hyperaldo. I mean, these levels are off the charts. But they're physiologic. They need the high renin, they need the high aldosterone to maximally hold on to sodium, to maximally reabsorb sodium, to allow for just normal tension, to allow for just the baseline blood pressure that they need to perfuse their vital organs, their heart, their kidneys, their brains. So what would happen if they get bitten by a snake? That would basically turn off the renin-angiotensin-aldosterone system. If they got captopril via a snake bite, their blood pressure is going to precipitously drop. It's going to go down to 60s systolic. They're going to go into shock. So that's why the snake developed the venom. But more importantly, it tells us why we have a hyperactive renin-angiotensin-aldosterone system. It's because our ancestors were on a low-salt diet. So what you can learn from that example is that if you have a very hyperactive renin-angiotensin-aldosterone system without any salt, that's fine. That's actually normal. That's normal physiology. But if you take that same potentially evolutionarily conserved hyperactive renin-angiotensin-aldosterone system and then throw it into a high-salt milieu, that is not going to be okay. And what modern hypertension might be is the kidney's attempt to reconcile a mismatch between conserved hyperactivity of the renin-angiotensin-aldosterone system and our high salt intake. Because again, you're getting thrown into salt overload. You're going into positive salt balance, and what does the body do? It raises the blood pressure to filter out that extra sodium load and reestablish salt balance, but you're doing so at the cost of being hypertensive and eventually at the cost of having hypertensive-associated morbidity and mortality. That's why if you look at populations in general, the more salt they're eating, the more likely you are to see hypertension. If you go to Japan, up to about 40% of Japanese people will be hypertensive, whereas if you go to the Eskimo population, which is on a low-salt diet, still a hunter-gatherer population, the rate of hypertension is less than 5%. Assuming that they have the same sort of genetic profile, because we all were evolved from the same ancestors, the same renin-angiotensin-aldosterone system activity is just the high salt here leading to hypertension versus the low salt here. So physiology versus maladaptive physiology. I like to use a term called relative hyperaldosteronism when I'm explaining to patients why I think their thirsty genes are causing them to become hypertensive. And you could also call this relative hyperreninism or relative hyperangiotensinism, but relative hyperaldosteronism is very easy to say. But essentially, if you take somebody who's healthy and you start loading them up with more and more salt, as you start to increase their sodium cofactor, they will suppress their renin-angiotensin-aldosterone system. And so if you're just following the aldosterone level, you'll see less and less and less and less aldosterone. If you do the same thing to someone who's hypertensive, they will suppress their aldosterone and renin and angiotensin as well. But they're just not doing it to the same degree as a normotensive. And so this is where we say, well, it must be in your genes. You know, you have some familial cause for hypertension. We don't know what it is. Well, I think I might know what it is. I think what it is that your genes don't allow you to suppress renin, angiotensin, aldosterone as well as a normotensive's genes would. And so people with hypertension have a renin, angiotensin, aldosterone system that they just can't suppress to the same degree as people who are normotensive. And so what you have is a relative hyperaldosteronism. For every amount of salt that's being ingested, the hypertensive has a higher aldosterone or a higher renin or a higher angiotensin than the person with normal blood pressure. That's why, when you guys are in your 50s and 60s and you're dealing with having high blood pressure and the person sitting across from you at the table is eating, a huge salt meal and they're bragging about how they're on no meds, you'll be able to explain to them why you hate them. I hate you. I hate you because you somehow have better ability to suppress your renin, angiotensin, aldosterone system. If you look at patients with high blood pressure, as blood pressure becomes worse and worse and worse, this is old JNC6 classification, so this is just saying mild hypertension, moderate hypertension, and resistant hypertension, the rates of hyperaldosteronism go up. So again, this idea that the worse your hypertension is, the less you're able to suppress aldosterone. Even if you take people with normal blood pressure, that could be most of you guys, and people with normal aldosterone levels. If you take those aldosterone levels and break it up into the lowest level of normal to the highest level of normal, from the first quartile to the highest quartile, the risk of progressing to high blood pressure, to having hypertension over the 4-year period, goes up from about 12% to 18%. And again, these are people with normal blood pressure and quote-unquote normal aldosterone levels. And even within that small window, there's an increasing risk with the inability to suppress your aldosterone level. I mentioned earlier that obesity is driving much of the hypertensive epidemic, and some of us believe that the way it's doing it is by feeding the renin, angiotensin, aldosterone system. So the adipocytes, the fat cells in obesity and metabolic syndrome, actually send signals to the adrenal gland to produce aldosterone. If you take zonal glomerulosa cells from the adrenal gland and you put them in a fat cell medium in vitro, those cells become hypersecretory and start producing large amounts of aldosterone. We don't know exactly what the signal is. We call them adipokine. Some people think it's oxidative fatty acid, but there is some sort of signal from fat cells that's telling the adrenal gland to massively produce aldosterone beyond what's physiologically acceptable at the level of salt intake. At the same time, being obese is doubly problematic because you're generally walking around with a higher volume overall. You tend to hyperfilter at the level of the kidney, and you get some hypertrophy of the proximal tubule, which, as you've learned, is where most sodium reabsorption occurs. So these hypertrophied proximal tubules avidly reabsorb salt. So you have both a high aldosterone level, a hormone that's telling you to massively reabsorb salt distally, and then you have expanded extracellular volume for more proximal reabsorption of sodium. You can tell this is going to be problematic. You will develop high blood pressure, and at the level of a kidney, you're going to hear about focal segmental glomerulosclerosis, but we see this secondary focal segmental glomerulosclerosis lesion that's very problematic and can often lead to kidney failure. That's why if you look at patients who are obese or have metabolic syndrome, they actually are incredibly salt sensitive. And perhaps the reason why they're so salt sensitive is because they have these hyperactive renin, angiotensin, aldosterone system. And what I mean by salt sensitive is that if you take a patient with high blood pressure, and if they have metabolic syndrome, which is in red, versus being of normal weight, they're more likely to drop their blood pressure on a low sodium diet, and they're more likely to raise their blood pressure on a high sodium diet. So their blood pressure is much more sensitive to salt. And we presume that this is primarily due to differences in the renin, angiotensin, aldosterone system between a lean patient and an overweight patient. And that's why if you just look at epidemiologic studies of patients with resistant hypertension, not surprisingly, on average, they're obese, BMI above 30. And on average, they have high aldosterone levels. Normal levels of aldosterone in our lab are 10 to 12 at the upper limit of normal. So on average, they're manifesting high aldosterone levels in the plasma and the urine. So to sum up that second theory of your thirsty genes, or what I call relative hyperaldosteronism, you could just ask, well, do we need an active renin, angiotensin, aldosterone system? Do modern humans really need this? And the answer is we just need the lowest level of activity of that system because we're eating so much salt. We don't need to maximally hold on to salt. We don't need to maximally reabsorb salt. But some of us who become hypertensive, our genes are still in that hyperactive mode. And we're basically maladaptive to the salt environment that we're in. And again, this calls for those patients to be placed on salt restriction. But it also calls for those patients to be placed on a renin, angiotensin, aldosterone system blocking drug, which you'll hear about more tomorrow. And this relative hyperaldosteronism, or what I like to think of as inappropriate aldosterone or you could think of it as inappropriate renin, angiotensin, and aldosterone in the presence of a high salt cofactor. That's driving a lot of hypertension, and I think it's the main driver of hypertension in the obese patient with metabolic syndrome. Okay, now the last theory I'm going to talk about is one of the newer theories. And I sort of like this because it's new. But I also like it because it ties in some of the other things we talked about. And this last theory is a dysfunctional gastrorenal axis. When you guys took basic physiology, was there a lecturer named Dr. Gershon, Mike Gershon? And did he talk about like the second brain? Okay. This is not exactly like that, but every time I see this slide, I just think I was in your shoes many, many years ago, and I just remember like hearing that second brain all the time. So essentially, because basically he was saying, well, the gut's a really smart organism. And the truth is it is, but it's not as smart as the kidney. So, but essentially, when we talk about the gastrorenal axis, what we're saying is that there is a communication between the GI tract and the kidney. And specifically, for me, from a blood pressure standpoint, is there a communication between the GI tract saying, I just got this salt load, to the kidney saying, okay, I'll help you get rid of it. A lot of cooperation, like when you guys do your team-based learning. So there's an observation that's been made, which is that if you give a patient 1 liter of normal saline to drink versus giving that same patient 1 liter of normal saline through an IV, perhaps surprisingly, they're going to excrete more urine and more salt. They'll get a more rapid and a greater natriuresis from drinking the sodium chloride than from getting it through the IV. So what that suggests is that there is some rapid communication going on between the gut and the kidney. I should know which organ's which. Between the gut and the kidney. And we think it's through some sort of hormonal signaling. Now, the two hormones that have been postulated as potential mediators of that gastrorenal axis are cholecystokinin and gastrin. They belong to a family of hormones that are secreted from the G cells in the stomach and the duodenum. They each have their own receptors, but they also share some of the receptors. But just for the purposes of simplicity, think of the CCK-A receptor as the cholecystokinin receptor, and then stop thinking about it, because cholecystokinin turns out not to be the culprit hormone that we think is going on. Rather, the CCK-B, or the gastrin receptor, is present in the kidney, and we think this is what's mediating that communication between the gut and the kidney. I told you cholecystokinin is probably not the main communicator, because if you give a patient a sodium load and you measure cholecystokinin levels, they don't go up, whereas gastrin levels do go up. And there hasn't been shown that there are specific cholecystokinin receptors in the renal tubules. In contrast, it has been shown that gastrin receptors are present in the brain and the stomach, but also in the kidney. And particularly, they're present in the proximal tubule, which is where most of your sodium reabsorption is occurring. But they've also been shown in the distal tubules in the collecting duct, which is where the distal sodium reabsorption is occurring. So these gastrin receptors are present in the proximal tubule, the distal tubule, and the collecting duct, which is where most of your salt reabsorption, like 99.9% of your salt reabsorption, is occurring. So that's why we think this hormone is going to be very important. So if you give a chronic salt load to a rat, and you look at how much sodium they're excreting, well, it's going to be about the same. But if you start to give gastrin to that rat, and what we're measuring here on the y-axis is fractional excretion of sodium. Fractional absorption of sodium. What you're going to see is that the rat with gastrin being infused is going to absorb less and less sodium. And when you're absorbing less and less sodium, you're excreting more and more sodium. So you're getting a natriuresis by infusing gastrin. If you block gastrin, if you give a gastrin receptor antagonist, you lose that natriuresis. So this is a nice suggestion that gastrin is mediating the salt excretion at the level of the kidney. If you then knock out gastrin from a mouse, if you knock out the gene for gastrin, you're going to lose that ability to get a natriuresis after ingesting a salt load. And not surprisingly, gastrin knockout mice do not have salt-sensitive hypertension. Now, if you remember, I showed this slide a little bit earlier. And we talked about the genetically hypertensive-prone rat, what's called the SHR, spontaneously hypertensive rat, and the normotensive rat, the Wister-Kyoto rat. And we said, if you take this rat's kidney, you put it in there, it becomes hypertensive. If you take this rat's kidney, put it in this rat, it becomes normotensive. And I said this is all due to blood pressure following the kidney, and specifically blood pressure following the kidney's ability to handle salt loads and efficiently excrete sodium. But now I'm going to make that even more precise, because this third theory suggests that what is really going on here is that blood pressure is following the kidney's ability to receive communication from the GI tract. And we'll show that in the coming slides. So if you take the Wistar-Kyoto rat, which is the normotensive rat, and the spontaneously hypertensive rat, and you infuse gastrin and you measure how much urine the animal makes, and specifically how much sodium goes out in the urine, only the normotensive rat in the setting of gastrin is able to get a diuresis and a natriuresis. And potentially that's why it's normotensive, right? It can respond to gastrin, it can get rid of salt, it can get rid of volume, whereas the hypertensive rat does not respond to gastrin. It cannot get rid of salt, it cannot get a diuresis. And so that's a big difference between these animals. How exactly is gastrin working? Well, you can measure at the proximal tubule the activity of the sodium-potassium ATPase, which in turn is measuring the proximal tubule's resorptive capacity of sodium. And if you infuse gastrin to the normotensive rat, you'll see less and less activity of the sodium-potassium ATPase, less and less reabsorption of sodium, so in turn, more and more excretion of sodium. This rat is handling the salt load by stopping proximal tubular reabsorption of sodium, and it's getting a natriuresis. And the signal is coming, we think, from gastrin. If you compare the Wistar-Kyoto rat to the hypertensive rat, there's no difference in the sodium-potassium ATPase activity. The hypertensive rat essentially is having no response to gastrin. And it's having no response to gastrin, and the result is no natriuresis and ensuing hypertension. So to sort of sum that up in a picture, what we think is going on is that you eat a lot of salt, your stomach senses the salt intake, sends gastrin to the proximal tubule, and in the setting of another hormone, which I'm not going to get into, called dopamine, together these hormones inhibit sodium-potassium ATPase. So gastrin signals to the proximal tubule and in turn turns off sodium-potassium ATPase. This is the gastrorenal axis. You stop reabsorbing sodium in the setting of a salt load. You get an ensuing natriuresis, and the result will be your blood pressure will be controlled. And if you can't do this, if you can't get a natriuresis after a salt load, potentially because of a defect in the communication between the gut and the kidney, you are going to become chronically hypertensive. So I'm almost done, but tomorrow you're going to hear a lot about different drugs that we use to treat high blood pressure. And when you're on the wards, you're going to be carrying around these books that tell you these are the drugs that you should use to treat hypertension. And they'll just say, use this class first, use this class second, use this class third. And I really don't want you to do that. I'd rather you think about choosing hypertensive agents based on the physiology. And this is what we do in our nephrology clinic. We basically say, am I going to go for a drug that goes after volume? You know, do I think that the blood pressure is primarily mediated by a volume problem, you know, a salt excreting deficit? Am I going to go with the drug that goes after the renin-angiotensin-aldosterone system? We try to figure out the physiology behind the blood pressure as we choose the agents. And the other thing that we do is we never try to say there's a one-size-fits-all for the hypertensive patient. There are a number of factors that can contribute to hypertension. I just sort of gave you 3 working theories. There's about 5 or 6 others that we just don't have time to go into. For example, the sympathetic nervous system in some patients with hypertension is in overdrive, so they have high levels of norepinephrine driving their blood pressure. And with each patient, you have to try to figure out which of the systems is off as you try to tailor therapy. So if you're looking at a patient where you think a high renin-angiotensin-aldosterone system is at play, for example, an obese patient, a metabolic syndrome patient, your first-line agent could be an ACE inhibitor or an angiotensin receptor blocker. Whereas if you're looking at a patient where the main defect is in sodium balance, for example, a chronic kidney disease patient, your big agent's going to be a diuretic. So you have to try to tailor it to each patient. And so to sum, and we will get out in plenty of time for small group, hypertension affects about 1 in 3 U.S. adults. Very common. It's a leading cause of cardiovascular and renal morbidity and mortality. And over 95% of the time, it's what we call essential. It's not identifiable. You cannot pinpoint a single cause of why your patient's hypertensive. You basically have to tell the patient, I don't know why you're hypertensive, but if you're a nephrologist, you want to look smart, you need to have some theories. And so now you have a number of theories to try to explain why your patients are hypertensive. But most of these theories come down to some defect in volume regulation, which in turn comes down to some defect in the way your body is maintaining sodium homeostasis. And the way I view a hypertensive patient, most of the time I say this person is in chronic positive sodium balance. And the blood pressure is their way to try to reestablish sodium balance. And they're doing so at the cost of being hypertensive. And that's why salt restriction remains, for the vast majority of hypertensives, the most natural way to treat high blood pressure. And that's why diuretics are one of the first-line agents we use and one of the most powerful agents that we use. So I'll stop there, and if there's any questions, please ask. Yeah.
If most of these do salt and no while you're overloaded, why isn't it like a Clarinone as well as number one treatment?
It's a great question. You asked the right person, because I actually think it's a perfect first-line agent because it has both a diuretic effect and a renin scintillator. So the reason why it's not is just because of side effect profile. So, well, the reason why it's not is primarily side effect profile.
Oh yeah, it causes like feminization, but that's not Clarinone.
Right.
Better for that, right?
Well, Clarinone is better. It doesn't have the feminization, but it's more expensive. So there's two things that are thought of in terms of public health deciding what's the best agent. One is efficacy, one is cost. And so the reason why diuretics like thiazides were really the first-line agent recommended is because they're the cheapest. But I agree with you. A very natural first-line agent, because it gets both the renin-angiotensin system and has some diuresis, is a mineralocorticoid receptor blocker.
And they don't really have that many side effects. If you don't have like that, they're not like you're not gonna go bald like you are beta blockers or whatever.
If you have normal kidney function, they really don't have many side effects. The one thing people worry about is hyperkalemia, but that's not a problem if you have normal kidney function. About 10% of people get gynecomastia, or with women menstrual irregularities from spironolactone, so that's doable. But you're preaching to the choir.
So
It was a very good
hypertensive
thought.
In 10 years, I'll take my
Yeah.
Clarinone. Also, isn't there a higher rate of salt-sensitive hypertension in African Americans?
Is there what?
Isn't there a higher? I think we were taught that.
Yeah, salt sensitivity. Yeah, so it turns out that African Americans, on average, tend to have higher renin, angiotensin, aldosterone systems than whites. That's a very broad generalization that I don't like to make, because the truth is that it's becoming harder and harder to say you're African American, you're white, because there's so much mixing of genes. But the traditional thought is that African Americans tend to have a higher renin, angiotensin, aldosterone system than whites.
Is that the same percentage as like the kidney disease incidence? Or like the same rate?
No, you're going to hear probably the better explanation for that at 12 o'clock today.
Thank you.
I had a question about,
Bedford.
yes, about prevention of hypertension. So we were given a lecture on COPD, where the lecturer said that hypertension was actually not a preventable disease. And if we can't, I know that we can't necessarily always identify the cause
Right.
of the salt imbalance, but it seems like it's safe to say that generalization is that your salt ingestion is inappropriate for your body's ability to excrete that
Yeah.
salt. So then, wouldn't a low sodium diet prevent hypertension?
It would, but the levels that I showed on that slide, of 1.2 grams a day, which would probably prevent hypertension, or even better if you could go down to the Yanomami 500 milligrams of sodium a day. They're not compatible with the normal human life right now.
They're not compatible with fast food, but aren't they compatible
they-
with like a paleo diet?
They might be compatible with the paleo diet if you're using no processed foods.
Right.
Yeah.
No problem. Well, that's what a paleo diet is.
But the problem with the paleo diet is that there's other problems with the paleo diet. You're worrying about your cholesterol and things like that. But the truth is that some people's genes are so maladapted that no matter what you do, you're not going to be able to overcome the thing. But the vast majority of primary hypertension, if they were on a less than 1.5 grams per sodium diet per day, probably would not need medication.
Okay.
So the thing is, it's hard to say preventable, because you are hypertensive, but you're managing it with a low salt diet.
Right. But I'm imagining the analogy of some people have protection against cigarette smoke and others don't. Well, then is stopping cigarette smoking, I mean, that's still preventable. It's a lifestyle intervention that's preventing the disease.
So there are some people, so I think what you might be getting at is the public health movement to restrict salt nationwide, and there's some people who say that's not fair. Because if you look at normotensives, they don't really get a benefit from being on a low salt diet. But what's never been shown is that it's deleterious to be on a low salt diet. So they're using reverse logic. So in the UK, for example, they did do a public health movement to basically cut down the amount of sodium in processed foods by about 50%, and they've already published data that the rates of strokes and heart attacks have gone down remarkably just since that public health. Well, something came out 2 days ago. I don't know. This came out about a year ago.
This is purely like for argument's sake. Is there a downside to like putting small amounts of diuretics in like the water supply?
Yes, there is. Because some people are normotensive. And if you put them on diuretics, they're going to become hypertensive. Some people don't need it.
Even if the way that they're working is it. But what's the difference between being on a diuretic and being on a low salt diet if you're normotensive?
Because the diuretic is essentially blocking the kidney's physiologic response. So the diuretic is basically blocking your ability to reabsorb sodium. You may want to reabsorb sodium. You know, for example, if I'm a marathon runner, I want to avidly reabsorb sodium.
I see.
If I'm running a marathon, someone gives me a cup of water that's got diuretic in it, that's going to be really dangerous.
Right, I see.
So the diuretic is blocking a physiologic response. Low salt diet is basically trying to reestablish physiology.
Right, okay, makes sense.
Your question, and I got to go downstairs.
Yeah, so my question is more about the pathology. Like in every case that you present in every theory, it's just too much sodium being reabsorbed. I was just wondering, is the hypertension always secondary to? I mean, I guess with the higher sodium, it means also higher volume. Is the hypertension always due to just increased blood pressure to get more filtration, or is it, I guess, in a sense, the volume overload itself just causes more pressure on like the blood vessels?
The high blood pressure itself causes endothelial damage. That's why you're getting that intimal thickening. But that's in turn sort of a volume mechanism. You think of it, it's sheer forces against the endothelium causing that damage.
So I guess because you also mentioned you want to increase the GFR to try and filter more
Right.
NA response.
But that's in the short term. Eventually having high blood pressure, you're going to reduce GFR because you're going to basically get ischemic
So
injury.
the increase in GFR is short term response.